Struggling with knee pain while dealing with a neurodegenerative condition or recovering from a stroke? Imagine juggling the challenges of arthritis or an acute knee injury on top of balance and coordination issues. Join us as we sit down with Dr. Amber, a leading neurophysical therapist, to uncover how these layers of complexity impact your rehab journey, discover strategies to regain control. Don't miss this eye-opening interview. Your path to better health starts here. Amber, it is such a joy to have you here. I've been looking forward to this episode for weeks, and I have to tell the listeners that I am thrilled to be able to have you on this show because I've enjoyed so much coming on as a guest on your show. But let's make this about some of the shared patients that we have. I know that you work with a lot of very special physical therapy patients, and I'd like you to kind of introduce the viewers and the audience to who are you and what kind of physical therapy do you do?
Absolutely. Thank you so much for having me on. I'm thrilled. Thank you. And so I'm a physical therapist, and most people think shoulders, hips, knees, back. In fact, when I tell people that, they usually have a story. I'm sitting on a flight and they're like, actually, my back has been one of those. And so it's wonderful because it really helps people feel comfortable opening up and talking about what pain is, why they would be going in. And we are not MDs. We are doctors of physical therapy, which just means that we are musculoskeletal experts. However, my area of interest is really musculoskeletal expert plus how does the brain and the body connect? How do they create pathways either to the brain or away from the brain? And that always interested me because I really love learning about the human body. But primarily, I always wanted to do pediatrics. And I liked pediatrics because of the learning involved. A child takes tens of thousands of reps to learn how to push their head up. And then they turn their head and they fall. And that experience on repeat drives its own pathway. And I think of it kind of like the Oregon Trail. One wagon went, but then eventually there was a rut in the road and every wagon went on that rut. So when we memorize a movement, we tie our shoes and you do it and you do it and you do it. And then you don't say the bunny goes around the tree, pull it through, and now I have two. You don't do that anymore because it's become automatic. So the brain has a prolific amount of information that it's weeding through all of the time. It's creating information. And it seemed natural that when I was doing pediatrics, I also worked in an area of the state where we really didn't have care for this other area of healthcare. And it was all the people with ALS, MS, the kids with CP and muscular dystrophy. And they were so incredibly underserved that there wasn't a therapist to see them for 50 miles. And a lot of people came from Mexico to our southern border hospital to be seen as well. And I was the only therapist that was willing to try. And that seems like not great, probably, because I was one of 20 and I was the newest therapist on board. But one of the things that I did have that the 20 others probably didn't have interest in is learning about new things, because I had just gone out of school and I wanted not to let people down. I didn't want to let my patients down. And so as we go and we develop interest in anything, we kind of go toward our niche area. And I have always loved kids, but then I realized that these adults were just as underserved as these children were. And it made sense for me to do both. It was a little bit hard at first because I was like, hey, can you turn over onto your tummy like to an adult? Because I was flipping between pediatrics and neuro. But at the end, it became this really beautiful way to be able to communicate with people in a simpler way. And with my adults, I found I could be more creative than I had been previously, just thinking about orthopedics. Because in ortho, there really are like kind of these nearly recipe cards of what you do to like rehab a knee, for example, to rehab a microdiscectomy for your back. And so you can follow this kind of recipe card. And yes, some therapists make it really interesting and it can be more fun. But I really like neurology and oncology, people who generally have a little decline. And we really have to be more creative to get them involved because they don't just need hope, they need to preserve function. And so when I think of people that really need therapy, I think of those people. I think of the people that I get to serve and this little area that is actually massive of people who really need higher level help.
I love that. You've just evoked images of like these information superhighways coming down from the brain to the limbs and going up from the limbs back up to the brain. Can you explain how those information superhighways can be affected in, let's define a neurodegenerative disorder, ALS, Parkinson's, multiple sclerosis, even some of the other movement disorders that you've mentioned? How is that highway affected? And then how does that provide a challenge to you as a physical therapist to keep that function maintained or at least slow the decline?
So those are fantastic questions. And I love this. I love talking to patients about this. So physical therapists can work in the regular outpatient clinic. Okay. I want to start there. So outpatient clinics essentially are what everyone thinks of when they have back pain and they go into a clinic. There are so many other areas of physical therapy that we work in. And a couple of them that really make sense are like the ICU or the hospital level care, and then acute rehab. So sometimes there's an injury or something that happens that you're unaware of, say a spinal cord injury. So you get in a really bad car accident and you're partially paralyzed from the chest down or maybe from the neck down. And now not only are you dealing with a loss of function, but you're also struggling with how much can I regain? What is my potential? So everybody knows the story of Superman. He fell off a horse. He had a spinal cord injury. I actually worked at the acute rehab hospital in Alexandria, Virginia, that he went to. And they showed him using like robotic technology essentially to do assisted walking in his rehab care. And people kind of think sometimes of like neurology as everybody's going to get back to walking at some point. There are limitations sometimes to what the body can recover. And science is advancing at an amazing rate. So it's not that there's not hope. It's that I need to know what area is actually affected, what the likelihood is. And I sometimes can base that off of the rate of progress of someone. So knowing what area of that pathway is affected is actually really important. Is it above the level of trauma or is it below the level of trauma? Quite often, if you have complete severance, it means that that function is not likely to return. But if I have partial signaling and some of it's getting through, then I actually may have a really good chance of getting some functions back there. But at first, none of them have any of it below. The trauma itself is essentially inflaming the situation and squeezing off the signal that goes down the end of the garden hose. So we've pinched it off essentially. Okay. And then gradually we can release some of that and oftentimes get some function. I have had many patients who have had terrible assessments, and this is very serious. When you go to a provider, you're expecting for them to be excellent, and not always is that the case. And I'm not slamming anybody, but what I am saying is you want as many providers as you can to independently do an assessment, not walk in and say, oh, you know what, you're paralyzed from T4 down. You don't want that. You want is someone who's going to come in and say, can you feel this versus this? Do these feel the same? Do you have, oh, that is a light touch. Interesting. Okay. So let's test a little further here. And then to see. So I had a man, he had a hip that was hurting and it started with back pain. And so they ended up doing a total hip. Boom, he got a total hip. And then he's like, my back and my hip are still really hurting and his rehab wasn't going well. And they did another scan and they found out that he had testicular cancer that was spreading to his spine. It wasn't his hip at all, but he had metastasis already to his bones. And unfortunately, that's aggressive cancer. And when I got him, he had massively swollen limbs. I mean, so swollen, I could barely pick a leg up from just the chair up. Okay. So that's a big deal. And you think about like, if you've ever worn a 5-pound ankle weight or gone to the gym and like kind of moved your legs around with quite a bit of weight, you can't do that much. And it's a long lever arm. So it matters when there's 5 pounds, 10 pounds, 20 pounds of fluid on you. This man was told that he was paralyzed from the lumbar spine, the low back down, meaning he's never going to move his legs again. And he had spent a year in a wheelchair. And I tested him because that's the standard of practice. I tested him. I got him in some different positions. And guess what? He definitely has function. Now, I treat this man and he actually lives on the other side of the country. And he said, I'm going to sell my house and move here. And I was like, no, you're not, because I'm not doing magic. I'm doing my job. I'm not doing magic. I'm doing my job. And we're going to find you a therapist that will do their job out there. And we did. And he walks with a walker now. Did I cure his cancer? No, I didn't. It's clear up to the base of his neck now. It's clear up. And I haven't treated him in a year and a half, and that man is walking with a walker. It's not magic, but if you have a therapist that's willing to kind of look at the puzzle pieces, you can really see where people have kind of skipped over. I do blame a little bit like the healthcare model now. It is designed currently to be massively productive so that we can see a lot of people. And unfortunately, that means sometimes a lot of things are missed because you're the patient, you're trying to explain it to me. I've got it, but I only have 10 minutes and I have 50 questions to get through. And then also I need to do an assessment on you. Let me feel, let me see this. Did I even get to that part? Can I see you walk? What are you able to do? So I really need to be able to do that. When we're talking about other things in the brain, like Parkinson's, that is essentially a go signal. Imagine that we're stopped at a stoplight and essentially you can never tell when the green light turns on. And when you do, it's very dim and you're like, wait, is it actually green? There's just not enough go signal for people with Parkinson's. And so their whole entire system is literally just kind of tired and melancholy, like the whole thing. And we call it brainy, meaning everything is slow movement, slow writing, everything is small and slow. But the therapy for that is actually amplitude and excitation. Like you really want to be a cheerleader for your patient. It's amazing therapy, actually. And the bigger you can get someone to move and the more ridiculous it gets, the more fun they have, the more it reinforces that they can, what it should feel like, what it should look like. And actually, they can have massive carryover from that. There are people who live very functional lives for a long time with the right kind of therapy for Parkinson's. Then the last kind is when the brain itself has an area that's really impaired. So we talked about the spinal cord. We talked about when the signaling in the brain is kind of slowed or diminished or something else is going on with just signaling. Then we have pathway disruption that is different. And what I'm talking about is like a stroke. So you have an area of the brain that essentially has, think of like it's the pit in the peach. It's the area that we don't eat. It's the not healthy tissue. And so that area has closed off. Now, the brain has a lot of redundancies for some things, but for some it does not. For example, I've seen stroke patients, and at that same hospital, I was on the brain injury and stroke rehab unit, and it's an amazing, amazing unit. It's a really miraculous timeline to work in. So these people are out of the hospital. They can't go home yet because like essentially they are paralyzed on one side of their body. Oftentimes they can't say yes or no consistently. They may not be able to tell you their name. So this is like a very heavy, dense stroke. That's proper terminology for it. It means a lot of systems are affected. Not like my pinky's tingling forever now and like I can't move it well. We're talking about very dense strokes. Sometimes people don't even know this is their arm. I had a lady that's like, come on, Lucy, let's go. But it was because we were training her not to forget her arm so it doesn't get burned or it doesn't get pinched in her wheelchair. Like that was a big deal. Don't forget your arm. Like it's over there. Don't forget you got two. Where's the other one? So sometimes that pathway is a little different. And when it's in the brain, you have signaling, and I always use highways, like literally highways, north and southbound highway. So ours here is the 101. So say we're going northbound 101, southbound 101. Okay. And what happened is that actually most of the time, partial of the lanes are blocked. Some of the lanes are blocked. And as we work, you actually see some of the sensory information, which is information from the environment. Ooh, that's hot. Oh my gosh, it's cold out. That's information to the brain. Information that moves our body is information the opposite way. It's southbound highway signals. And as we're going, you see clearing of the lanes. Sometimes they don't all the way clear, and sometimes they do. And often it's in the processes by which we are waking the body up and stressing the brain. And it's about intensity and repetition. And I go back to that pediatric work, and I go back to that basics of foundation of how do babies learn to move? There is a science to it. Almost all babies on the neurotypical pathways develop in the same patterns. Not exactly the same timeline, but they all essentially develop on the same patterns. To be able to run like an athlete means that you developed in the neurotypical way. And it doesn't happen for everyone. We've all seen babies kind of maybe that scoot like this with their legs or do the army crawl instead of regular crawl. And they may totally walk normally. When we are talking about patients who've had massive brain injuries, the rehab is different One, because they are aware that they cannot. I hate that part for adults. It crushes me a little bit because I sit there and I go, listen, I want you to fall asleep dreaming about doing this. I know it's going to hurt. Like it hurt to stand up the first time. And with stroke patients, this is a big thing. The first time I get them up, very often, they've been in a bed essentially for like 3 weeks in the hospital being stabilized. And that's not that atypical after a really dense stroke. And they weren't able to move anything. And they've just grasped that their body's paralyzed, just mentally grasped. Another week in, they are struggling with the fact that this may be permanent because they have just realized that this may be something they have to deal with. And at the same time, I'm seeing them maybe 2 hours a day, 5 days a week, because inpatient acute rehab is 15 hours a week of therapy. It's amazing therapy. And so the first time I get them up and I brace their knee and I've got their hip here and I'm pulling their knee and I'm locking them into place, okay? It's uncomfortable. And I tell them before they get up, like, this isn't going to feel good and we're going to do our best. And what I want you to do is beat your own record. 30 seconds, 15 seconds. And I promise you tomorrow it will feel better and will get longer. And you're going to fall asleep thinking about it. So these pathways start clearing. We get return of function. And we just want to maximize that as long as possible. If I could, I would give every single person who had a massive neurologic issue 1 year of acute rehab. Not the average is about 13 days nationwide of acute rehab. It's just enough to get you to walk about 50 feet with or without assistance, be able to roll in bed and get to the toilet so you can be at home safely. The idea is that you go from acute rehab into home instead of into the other kind of rehab, which is called skilled nursing facility. Now, saying all of that, that's a lot of information, but this is why there are now 20 different specialty areas of physical therapy. And it's important to know if your therapist is a regular physical therapist or, generally speaking, like an orthopedic therapist. And it's a good idea to know what their other areas of interest are. If you have something going on, there are specialized oncology PTs. I have a program that I went to that's called PORI, and it's Oncology Rehab Institute. It's specialized out of Denver. And I had no idea, even before I went, the impact of swelling on someone with like face or tongue or head and neck cancer of any kind. That muscles are being pulled and their face is essentially disfigured, but we can remove pain and swelling and improve function because of their radiation and chemo that has essentially burned their skin. Like, there is so much we can do, and we're constantly learning what we can do more.
Wow, that's a lot. So if we bring it back around and touch base then on a patient who already has something like a neuro disease or has cancer, and then they develop an acute pain on top of that. So they already have this diagnosis and they already have these challenges because they're not 100% rehabilitated. They're at day 65 instead of day 365 or something. How does that throw things into the mix with regard to you as a physical therapist looking at an acute on chronic or an acute on something that is longer lasting?
So I've seen it both ways. I've seen it where a joint pain shows up and it's actually a sign of something neurologic. That's interesting.
Like the hip pain or the back pain, it was actually testicular cancer that had gone into the spine.
Yes.
Okay.
And then I've seen the other. And in the other form, say I have a patient who had a stroke 13 years ago or a brain tumor that was removed, and they're one of the lucky ones that have made it a really long time very functionally. Eventually, unfortunately, with the weak side of stroke, oftentimes what will happen with that is you'll see a hyperextension on a joint or a bracing where you push on a bent joint. So one is restriction where I can't straighten it all the way, and one is restriction where I end up using my ligaments, and that can cause joint deterioration. And it's not based on muscle control when I'm doing that, when I'm hanging on the joint. And some people have kind of seen people, I'm going to actually stand up for this part, but might have seen people where they're kind of slamming their knee back when they stand or walk. You've seen people like kind of doing this slamming. I've seen them crossing the street. That's like the commonplace. You're kind of like, what is going on with this guy? He's like stepping up and slamming his knee back. Often that leads to massive joint degeneration. And if they have the appropriate, sometimes we have to use bracing to like bring their toe up and push their knee forward so they're not slamming on the back of their joint. However, just like anything, if I sit here and do this long enough, the joint tissue will eventually stretch, and then I have to put it on more tension to bring it back. So there's that case, and that joint degeneration can happen fairly rapidly because of how they're using their joint. Like really it can. The other kind is the weakness kind, and the weakness kind often leads to more of a crouched position. We've all seen the people at the grocery store, and now they're this way. They're on their grocery cart and they're kind of stooped forward, or they're pushing up constantly. And people are always saying, you should bring your walker up. It's too low. You're bent too forward. They've got it. An expert has assessed the height of that, I'm sure. And when we are doing that, sometimes they actually don't have the range. And what's unfortunate about when people are aging and they have a neurologic or a balance or coordination issue is the number one thing people see is that you move slowly, then they talk to you slowly, and they constantly ask you to sit down. Oh, you know what? Here's a chair. And so they're not practicing moving like you and I are. And like half the time they're perfectly capable. Like really, they got into the post office on their own. And so like treating them as if they shouldn't be standing or shouldn't be practicing is actually maybe not, in my world, that's not kosher. I want to treat them like they are fully capable all the time. I speak to them in this tone, just like I speak to any of my colleagues. And I have to say that they appreciate that. They want me to treat them like I would treat anyone else. So when we treat people like they're impaired, they are impaired. I'll always only have that like limit of, oh, you're capable of this in my head, instead of, what? I saw you do that 80% of the time, you did it wrong. I know you can do it 20% of the time. So I need you to stand up and practice that. And this is going to be memorized this week. So there's a level of accountability for something that they're capable of. Now, sometimes the crouching is actually a limitation. So a lot of times we don't lay on our stomachs anymore. We're not like working our butt muscles appropriately. We don't ever arch our backs back. And so gravity starts winning. And I mean, this, you could see 50-year-olds that are fully flexed. They're starting to get hip flexor contractures, knee contractures. And then you think of like the average 70 to 80-year-old now. Now, I have a patient that's 101. I have another patient that's 95. So I have people that move really well and are independent of a device most of the time. So I know that aging is not a number, but when we think of like people in the US that are 70 or 80, we usually think of like a little crouched person. Their knees are kind of bent forward and their hips are kind of bent. And when they do that, they're actually in a position where their weight is not appropriate. And so because their hips are bent, their knees have to be bent so that their balance can actually stay over their feet. So they have to get lower and lower and lower. I actually think of that as like a little drunk person. Wide feet or crouch to the ground. Whoa, they're getting input from the ground. They're getting close, and it makes them almost more likely to fall. So when we can pull them up, when we can create confidence, balance, coordination, and the joint stacking that we need, I think of like Legos. If we take those Legos and they're all square and we just stack them up vertically, they look really good. As soon as I take one and offset it, boom, 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 boom. Now it's starting to tilt. And I have to put more weight on this side to keep it even. So that's like your head forward and your butt back. Whoa, where's the balance on the teeter-totter? So it's a lot to consider. Now, the only other thing about pain for patients who have like neurodegenerative diseases. So I primarily treat dementia, Parkinson's, and brain cancer. Okay, those are my top 3. And it's not that those are the only ones I treat. And sometimes people fall into my lap that definitely have one of those and they had no idea. And that's more rare, but I actually find that PTs do commonly find Parkinson's disease because people are tripping, they have bad knee pain, and they're like scuffing, and they literally don't know because their brain isn't registering how small they're getting. They aren't registering it. And then you write a little note and say, hey, I'd like you to look at these 4 things to their primary and hopefully ask the patient like, hey, you might need a neuro referral for this. Something else might be going on. That's about the limit of what we do. We don't go, oh my gosh, you might have ... Like we don't do that because we're not diagnostic MDs. So when we're doing that and we have pain, the other limitation for people often with like brain cancer or anything that's neurodegenerative in nature is that those patients cannot withstand sedation medication. So like if they have a bout of confusion and they go to the hospital, oftentimes they might have things like visual disturbances or delusions, essentially seeing things that aren't there. And sometimes they're scary and sometimes they're not. So like people with dementia go through this a lot. So I had a lady and she had like 20 Santas in a collection at Christmas down her hallway. And I walked in the hallway with her every day and they started scaring the crud out of her. I mean,
Oh,
she was so
no.
frightened. And I had to take them all down and hide them while she's panicking and losing her balance. And I knew because I'm standing with her and I'm looking at what she's looking at and I'm trying to reassure her and turn them away. She was frightened. Now, she's seen them a million times. And it doesn't have to be something that looks familiar. It could be, this is all of a sudden something gigantic and it's coming at me. It doesn't have to be real, but it's real for them. So sometimes we have to kind of reorient. It can also be people. And so unfortunately, a lot of times people with those kinds of impairments do actually get sedation. And then it's hard for them to come out of it and they have a harder time. So sometimes people that don't tolerate being put under, essentially like having anesthesia, they are not really candidates for surgery. And they may have not found that out until they went to the dentist and had a really hard time, or they went for a different kind of procedure and had a really hard time coming out and had to stay at the hospital for a day or two. And then we're like, interesting. Okay. And he was combative. He's never combative. Just the nicest person in America. So we have to really put pieces together. I think it does go back to like providers doing a whole assessment of what's going on, not just asking the questions that are like most commonly asked for everyone else. We really have to put like our magnifying glasses on it and be like, oh, that doesn't sound quite, let's dive into that. What's going on there? So often those patients are not really candidates for things like total joints. So it's way more important to identify the proper impairment and work on it. There are plenty of people who get away with not having a total knee or partial knee or a surgery of any kind with a lot of different kinds of procedures or with physical therapy. Again, not all therapy is created equal, but there are other things if they can't get through a pain point to help them tolerate therapy better. And it's not all prescription. As you know, there are a slew of injectables that are on the market right now. And going to your expertise, many of those are options for people who may not want surgery, cannot afford surgery, cannot afford the time off from surgery, or don't have anybody to help them after a surgery.
Absolutely.
So what are some of those? People always ask me like, what's the best?
Well, let's start on the anesthesia part because I hold that too. I absolutely have this hard line in the sand where benzodiazepines like the Xanax or the Ativans or the Midazolams, the Verseds, I believe there's a point where you do not give those to a patient. And my cutoff is actually 60. That you'll see a lady who's 80 and she's taken 2 or 3 Xanax a day and has for the last 55 years. And she's clearly a different story. But in general, we can show that the use of benzodiazepines as you age decreases your ability to tolerate the anesthesia. You actually have an increased risk of post-operative dementia and can take so much longer to clear this. Midazolam should clear the body in about 20-ish hours, maybe 18 to 20. But you'll say, my mom underwent an anesthetic and she was not herself for a month. Like she had a benzo. She had a benzo and a benzo should not be. So I completely agree with you. There are meds that have a shorter half-life. We're not going to get into pharmacology today, but just knowing that something is cleared in more like 40 minutes versus something like 72 hours, big difference there. So you can make some changes, or you can do something like a spinal anesthetic if they have to be numb from the belly button down for a procedure, but there are just so many other options.
Yeah.
If we do talk about they don't want surgery, they're not a candidate for surgery, they can be too sick for surgery, but not sick enough that they should be bedbound, then what are my options? I'm still in pain. I still need something to be done. We partner with the physical therapist. We partner with making sure that they are braced appropriately. If they need to be using a cane or a walker or a special brace for their foot because they've got a foot drop and they're slapping that foot down because they can't lift up the toes. But we can use their own cells in many instances if they've had
exciting.
blood, platelet-rich plasma. We can use bone marrow. We can use adipose or fat. There are some things that we ask people as they age. Do you have a history of, are you actively being treated for a cancer? You've mentioned cancer. If you've got a bone marrow cancer, we're probably not going to use your bone marrow. If you have a blood cancer like lymphoma or leukemia, you've probably undergone chemotherapy. You're not a good candidate for using your blood. We won't have the same number of growth factors. But existing other than that, without those specific little things like you're on a super strong blood thinner and your cardiologist says if you stop it for even a couple of days, you're going to have a stroke or your AFib's going to go crazy, then we can come off of blood thinners like aspirin and we can collect your own body blood or bone marrow or fat and we can put that into the joint. And we're getting more and more data every single month that's being published. So that is an option to look at in conjunction with all the other things. Do we need to look at the inflammatory eating? Do we need to look at the sleep? If the sleep is bad, then you're not healing in your sleep. So is there polypharmacy, as we talked about, going on there? Too many meds that are on board. Do we need to peel off some of those and let a person get some sleep? And it's amazing what things like inflammation can go down with that.
I love that you say that, because a lot of times people don't understand how stressful pain is on the body. And unfortunately, there's a book called Being Mortal. I'm sure you've read Being Mortal. It talks essentially about the callousness of medicine to patients and about the misunderstanding of the role of doctors to patients. It's a fascinating book, but when you see 100 people a week and 100% of them are coming in for pain of some kind, sometimes providers can stop hearing that word. And unfortunately, that just means that we are a little more responsible for the messaging that we're getting across, and we need to be specific. And we are responsible for the message that they're going to get in that 5-minute period or that 10-minute period. And so when we're talking about like what we can and cannot do, I love physical therapy for one of the best things I think about it are that I see a patient more than any other provider. Unless you have a caregiver, you're not seeing anybody more than me. And so I have a lot of data points, like you said. I see some patients 3 to 4 times a week. That sounds crazy, but it is exactly what they need. And the reason I got to that point was probably because they had, like, say, a hospitalization for pneumonia, and they went immediately downhill because they were bedbound essentially for 4 days, and now they can't walk again. And so the intensity, the frequency, the ability to figure out a way for you to do what you want to do no matter what. So like, say you walk with a walker and you just cannot get off of it. I know you're capable. You have the strength, you have the function, you have the balance, but you are so scared of falling because you broke your hip that way. How can I make this situation safer for you? Well, maybe we put you in the pool. We're not bringing the walker in the pool and the water holds you up. There are a slew of creative resources we can think of and help you with. I mean, I've put people on hospice. I've graduated people out of hospice that were essentially massively ill. I had a guy with pulmonary fibrosis, and he hadn't been out of bed in 9 months. And he got home and it was so painful for him just to be in a chair. I mean, the difference between being reclined and then being in a chair position, his back could not tolerate it. And we're just like shooting for seconds. I'm doing hip stretches. He was so uncomfortable. And we went into the water. And that actually came from inspiration from a classmate of mine that referred him. She lives in Hawaii, and that's what she does. She does pool therapy. And so she was like, Amber, let's get him in the water. And I was like, why didn't I think of that? Well, because I have the same stigma. Like, he's so sick. How am I going to get him in the pool? And we did it. So where there's a will, there's a way. Yes, you can keep people safe. Yes, you can keep them challenged. And then guess what happens? The more challenge they have, the better the change is. And this is all the way through. And I love claiming this. I treat from diagnosis through end of life. So I see people at the very end. If they happen to choose life support, I'm there with the family for that part too. The whole thing, the whole enchilada. And I love that I get to treat people in their homes. I love that I get to meet their families. I know their kids' names. I know their dog's name. I know their second cousin from wherever. And it lends to make sure that the things that they think are important, the ways that they choose to live and pass, are respected. I have a patient who frequently flatlines, and it's an interesting thing. I've seen him do it 3 times in a session. And the call is usually call 911 right now. And his wife's there. And I'm like, we're measuring everything. We're doing vital signs now. We're tracking everything. And we're talking about this process of if this is the end in his own home, because he does not want to be in the hospital. And we have a number to call if he's all the way done right now. And that's to do organ collection. Like, so someone can announce this and then help with the part that he wants to make sure goes to future people to help them. And like, I love the process by which patients who know that there's an end get to choose. It's so amazing. It's like a second lease on life. Like, what's important to me now? Well, I wanted to fix relationships with my family. I want to go like fish off the Rio Verde, like whatever it is. I want to drive a race car. I want to go play soccer with my grandkid. Like, people get into the function purpose, their real goal, and that tickles my fancy. That right there. I have had it the other way where I didn't get to do that with a patient. And it was one of my very first brain cancer patients. And he kept making excuses and I let him off the hook. And we didn't end up getting to do it. And I'm never going to let that happen again, because it changes everything for everyone. It changes how hard people work, how grateful they are, how they see their life. It changes everything. So that's what I think physical therapy really should be. I think we have a greater purpose. I don't want to say I get offended by like how people look at our profession, but I do want to hopefully make my profession think a little deeper about the purpose of their job and the purpose of the relationship that they have with another person that they're taking care of. Like, it goes deeper than this. It really does. And it really is driven on helping someone live a really full life, no matter what stage of life they're really in.
Absolutely. You've talked about so much here with regard to function. And that's some of the things when you meet person for the first time, when I meet a person for the first time, you say, where do you want to be? Paint this picture for me. Where do you want to go? And that's absolutely what you're doing with them. But Amber, what hasn't been said is this is not a typical physical therapy practice. I don't know anybody other than you who can take somebody from diagnosis to death. I don't know anybody who has that kind of practice you do. So just to kind of set the record straight, how do you do this? Because I don't think it's within the confines of the current sick care system.
Yeah, so absolutely, you're correct. So my practice actually parted ways with insurance as a decision. I've worked in everywhere from the Northern Arizona reservations and school systems to some of the best hospitals in the country to the skilled nursing facility that is associated to the Phoenix VA. And I have always loved my profession, but I didn't always love my job. And I knew that more had to be done, that I would go home really frustrated at the limits of how I could treat someone, the way I could communicate even with other providers through like this little portal system, and if my note was ever even going to be read. And that was when I decided that my job needed to be bigger. In all fairness, I didn't like come up with my business model. A classmate of mine who was really like, he had completely different skill sets than I think all the people in our class had. And a couple years out of school, he didn't get a director position and he started his own clinic, cash pay clinic. And like, I looked at him and I was like, what? You did what? And he's like, yeah, and I'm crushing it. And I was like, okay. So he showed me this stuff and I was like, what? This is weird. Medicine and business are not supposed to be married. Like, we're altruistic. This is not about making money. I'm supposed to be making teacher salary, which I do. Like, we're the teachers of healthcare. But how do I get to this point where you get to see a patient for an hour? Just you. That was so enticing. And then you get to build a business out of that. Okay, wait. And I get to pick what kind of patients I get to see. Oh, you're going to give me those because you don't like them? The inspiration for my business came out of all the stuff that nobody else wanted to see. It came out of doing it better than other therapists did. It came out of being a little more caring. And it came out of really a need from the community of the marriage of what I had done and what was being about to happen in healthcare, which is what we're seeing now, that people really do want more privatized care. And it's because this system has let them down. Previously, I would see 13 patients back to back for 40 minutes straight. There was no minutes in between, and you're timed. So if my patient walks in 5 minutes late, I am stressing out. And on most of those sessions, they're seen by a PTA or a tech. And like my voice is rapid because it's stressing me out just thinking about how this used to be. Some people in outpatient clinics are seeing 25 patients in a day. They put hands on a patient for 5 to 10 minutes, then you're handed off, then you're handed off, then you're handed off. You could be there 70 minutes, but you saw your PT for 5 to 10 minutes. I do not subscribe to that model. I cannot oversee your care from over here. And also, I'm sorry, but I don't need to see you like ride a bike. I'm going to assign you that as homework and say, did you do your bike riding? And then I want to get to the other stuff. I want to put my hands on you. I want to keep you challenged. And I will say during COVID, this was like big. I have a lot of neuro patients. It was really hard because I don't have my hands on them to keep them safe in a session and as challenged as I did before. Because if I'm not here holding you and keeping you safe and you totally trust me to do this, we're declining because we're not challenged enough. And like, yeah, I can ask your wife to stand there, but is she gonna catch you if you're going down? Like we had to do some serious training for that. And still I don't know. And it's my liability. So when I am not afforded that opportunity, I just really think that the inpatient model is the best. And then the other difference about my business is I go to people's homes and their work. So I treated a dentist in his hallway once for 9 sessions because he couldn't feel part of his fingers. And he's like, I need to be able to work for another 1.5 years because I'm going to retire anyway. But if you can get rid of this, that'd be great. So we bought a 10-pack of visits and I used 9. And then his wife ended up needing something for her neck and boom, cool. So it depends. But I love being able to go to people's homes too because I see the situation that they're really in. What is their support like? What are they like on a bad day? What's their bathroom actually look like? Because you can tell me what your shower looks like, but some of these homes in Arizona have no stairs, and then all of a sudden there's like some sunken step outside and stone inside the house. That's fairly atypical. Like there's flagstone in some of these homes here. And there is a big deal that goes into seeing someone's private living space. And it also deepens the relationship a little bit. Like when they're having a hard time because they have incontinence, they're telling me that because they trust me and I'm not in a clinic with 20 other people. So it just is beautiful. I don't ever plan to change my business model. I've been asked a bunch of times, like, are you going to open a clinic? I'm like, why would I? Seriously, why would I? I get it. It would be more convenient for me. For me, it would be. I wouldn't have to drive to my patients' homes. But for me, I actually find that to be the benefit that my patients enjoy the best. It's not just the convenience. It's the quality because it's provided in their home. It's the comfort of them knowing that if they're having a really terrible day, I'm not parting ways with them. I'm coming back with them. Like that's the thing. So I love what I do.
I can tell you are so passionate about it. And I can't help but see that patients won't benefit from, particularly when we're talking about in-home care. You have expanded this 13-day rehabilitation to beyond, to the true. I love your ideal of it should be a year after something massive like that. And you're kind of allowing that in the home, and you are aware of the intricacies of the number of steps to the bathroom, the number of steps to the bed, the number of steps to the kitchen, and all the things and all the obstacles in between. How can that not be the best thing for the patient?
Yeah, totally. I love it.
I do too. Congratulations on your model. It seems so patient friendly and so, I don't know, just overall best for what we need right now in healthcare. And I hope a whole bunch of eyes are on it. Is there something else that I am missing with regard to something we should all know about what you do and how patients with pain, with neuro issues or cancer or end-of-life situations, that we all need to look at that differently?
I love that. Okay, I want to say it with a story again. I was walking down the street and someone I was with pointed at someone who, we were in LA, pointed at someone sitting on a stool that was passed out and looked like they might have been on drugs, like really, like that had been it and they'd passed out, and was like laughing at them. I think everybody can kind of like imagine this situation. Somebody doesn't have, and we're laughing at them. Unfortunately, that happens way more often than we think. If you see a patient with dementia or Parkinson's or Lewy body and they like start opening their mouth, you might speak to me differently. You might start yelling at me because I speak slowly or I take a few seconds to process. I think that that is unacceptable behavior. We are humans and we need to treat other people like humans. It doesn't matter if they're going through everything, like the person on drugs on the corner, the person who's poor living in a tent, the person who's talking to themselves walking down the street, or the person who cannot process information the same speed that you can. You could even go to people that don't speak your primary language. Like, it takes them a minute, okay? Your brain takes time to process. Your face might have different reactions than you thought. They are not stupid in there. Their brain is probably firing. Just because they're stuck in a bed doesn't mean you shouldn't talk to them. Just because they process slower doesn't mean you shouldn't make the same jokes and smile at them and use the same kind of tone you would with your friend normally. So if you know someone who's going through this, call them, make a joke, have a good time, speak to them normally. Please don't treat them poorly. And you may not know you're doing it, but there is a stigma on mental health, physical ability, disability, neuroatypical. Like, we are blessed if we don't have that. And just keep that in mind, that you should treat people like they're blessed and you're blessed to be around them anyway, no matter what stage they're in. And the other is speak to people who you think cannot hear you. There's tons of research that says that they can. Whatever you need to say that will make them feel better, I promise you it will. I promise you it will.
Absolutely. Very well said. I speak to people who are under anesthesia and I know that they can hear. As they're waking up, they're transitioning. You know that it's there, right? You know that somebody can hear. Amber, that you are a beautiful soul. How can we find you? How can we connect with you? I would love the world to know about you.
Thank you. Okay, so Dr. Amber Enright. My company name is called The Therapy Doctor, and my tagline is Moving You with Heart. My website is AZ, like as in Arizona, AZ Therapy Doc, because that's where I live. And if my phone number is necessary, 480-797-1403. And I hope you guys contact me. And if you have questions about finding a great provider, I actually love helping people find great people too.
You are one of the best matchmakers in this healthcare arena that I've ever met, and I appreciate that. If you didn't have time to jot all this down, it will be in the show notes, I promise, and we can connect you with Amber and the amazing healing that she does. Dr. Enright, I am so, so blessed to know you, and I appreciate everything that you've shared with us today. Thank you so much.
Thank you, Tammy. You have a good evening.
You too.
If you have knee pain and would like to learn more, I have a worksheet called 5 Things to Do Now to Reduce Your Knee Pain Within a Week. Go to www.kneeboostnow.com to download it for free. I'd love to hear from you, so please like, subscribe, and comment below so I can help you get out of your knee pain.